addictions, violence globally. And we also know that LGBTQ plus communities have higher prevalence of drug use, higher risks, and also experience higher repression from derived from that drug use, criminalization, stigma. So if we want to have better drug policies, better services, we have to acknowledge this reality and understand that communities are not uniform, they are diverse, and we have to have a more complex portrait of the reality if we want to have an approach that it's not superficial. And that's why we have to have this lens of intersectionality to address better the reality and the challenges that we have ahead.
You have extensive experience in policy advocacy within European context. What have you learned about building alliances across movements, drug policy, LGBTQ, HIV, anti-racism to achieve systemic change?
Alliances between movements are historical. LGBTQ plus communities and HIV activism have for a long time have worked together and changed the history of health and social movement. And we have the understanding that we cannot work in silos. So we should not aim to have better health policies if people don't have a place to live, for example, or if they experience repression, and so I think we have been doing a movement or having a bigger vision of society and understanding that people are not unidimensional. And of course, this comes with sometimes some tension. So some social movements would prefer to work only on their specific sector. I understand why, because sometimes it would make life easier and simplify the need to commit to complicated positions. But I think it's impossible to move forward and conquer rights and a better place to live if we don't address all aspects of society, because we are not only one thing. So social movements should work together. That is not always the case, but I think that's something that we should aim, let's say.
From a governance and human rights perspective, what minimum standards should international drug control bodies adopt to ensure that intersectionality becomes an operational principle rather than a buzzword?
Well, policies and services working with vulnerable populations as minimum should have the right to exist, because existing right now, it's already something. We are experiencing enormous amounts of cuts in funding and even the attempt to not address policies that work with vulnerable communities. So that's the starting point. Then the second thing I would say that is to create safe spaces that make people feel safe and visible, to start to address, for example, the needs of LGBTQI plus communities that use drugs, and use the experience of communities, engage with the communities, co-design solutions. So that's another thing. Another key aspect is to integrate realities. So we have to connect drug policies with health responses, with social responses. So we have, and also mental health and so on. So we have to achieve that policies and services can integrate care and visions. And in another aspect, I would say, is that we also need to have data, because many times we don't see minorities and LGBTQI plus people reflected in reports, in data. So in many cases we are invisible, and if we are not there, if we are not visible, so we are not part of the reality, and our needs will not be addressed. So I think this all combined should make us achieve better services and better policies.